Okay, so as Tammy said, I'll be talking about medication management and the symptom burden, as well as some highlights on management from a non-pharmaceutical standpoint. Lily will be covering that second half. So just some conflicts of interest to disclose. I do have consulting agreements with various pharmaceutical companies listed here, and I get grant support from Jazz Pharmaceuticals and Harmony Biosciences, but we'll endeavor to present a balanced view of medication management. So I think most people know this, but as we go through the different medications for the treatment of narcolepsy, I think it's helpful to understand what these medications actually do, because essentially we're using other chemicals in the brain other than orexin currently to improve wakefulness. So when we're thinking of wakefulness, there's a whole concert of neurotransmitters that help promote that arousal state. Those come from different areas of the brain, the locus coeruleus, the tubomammary nucleus, dorsal raphe, and others. But functionally, these are chemicals like acetylcholine, histamine, dopamine, serotonin, and noradrenaline that helps us maintain wake states. And what orexin serves to do is act like a finger on that switch to keep those neurotransmitters on, essentially tonically active. When we sleep, those neurons, including orexin, are all suppressed by an area in the hypothalamus called the ventrolateral preoptic nucleus through a chemical called GABA. This switch is what I was talking about. So when we talk about these neurotransmitters, again, the orexin is helping it stay on, so active. And so when orexin is lost, you can get sort of a decrease in the ability to sustain this wakeful state. And so people have difficulties with daytime sleepiness. For reasons we really still don't understand, at night when orexin is lost, there's this incredible fragmentation that sometimes is seen, and we call that disrupted nighttime sleep or sleep instability. You'll see different terms for that. But this is a patient who in green is the wakeful periods, and you can see there's just a lot of oscillations between sleep and wake for this particular patient. We don't really know why that happens, but it's possible that when orexin is lost, that there's some imbalance in this sleep switch. And perhaps some of the neurons in the wake state that should be suppressed are not fully suppressed. This term disrupted nighttime sleep is probably an umbrella term for a lot of different comorbidities that occur during the nighttime. So I described sort of the sleep instability that emerges when patients have a loss of orexin neurons as that happens with narcolepsy type 1 or narcolepsy with cataplexy. But there's a whole number of other comorbidities that can occur, including what we call non-REM parasomnias, so sleepwalking, sleep talking, and maybe more specifically nocturnal eating disorders where people get up, eat large quantities of food, sometimes even really bizarre food like frozen bacon, for instance, and it can be very disturbing and contribute to weight gain. REM behavior disorder, so reenacting dreams, talking in sleep, that's like very like consistent with a dream that they might be having or acting out that dream. Obstructive sleep apnea is present in up to 25% of patients. Periodic limb movements of sleep, which is basically a lot of twitching that can occur during the night. Vivid dreams, nightmares, and even central sleep apnea has been reported in children with pediatric narcolepsy. So in terms of cataplexy, we went over sort of the chemistry of what helps with wakefulness. I'll simplify this to just say that there's an area in the brain called the sublateral dorsal nucleus, and that's our paralysis circuit. Everybody has one. And when we encounter a very strong emotion as humans, for reasons we don't really have the full mechanisms of, but it gets processed through an area of the frontal cortex and an emotional area called the amygdala. And that activates that paralysis circuit. So when anyone laughs really hard, you kind of feel a little like head drop or your knees might buckle. But in people without narcolepsy, they have orexin, and orexin serves to kind of put a brake on that paralysis circuit. So when orexin is lost, that can activate that paralysis circuit. And we're relying on medications that increase things like norepinephrine and serotonin to reinstate that paralysis circuit and prevent cataplexy. There's a range of medical comorbidities that can occur, obesity being probably the most common, reported in up to 60% of patients. In children, precocious puberty can occur in up to 40% of patients. As I mentioned before, obstructive sleep apnea is fairly common, and sometimes this might be a cause for why a patient might be misdiagnosed for a while with obstructive sleep apnea. They think the sleepiness is related to that, and then eventually, when it doesn't improve with treatment of obstructive sleep apnea, people kind of delve for further diagnoses. Hypertension in the adult population has been reported in up to 41% of untreated patients, and then that number goes up to 58% on stimulants. And I'll show you some data that Lily collected more recently. And other comorbidities include GI side effects, dysmotility, constipation, irritable bowel, headaches as well, and other endocrinopathies like thyroid problems. I think the thing that we have been studying the most in our center has been the behavioral and kind of mental health challenges of narcolepsy. So attention deficit hyperactivity disorder, even attention deficit disorder, has been reported in up to a third of patients with narcolepsy. That's narcolepsy type 1 and type 2. And oftentimes patients describe symptoms of brain fog, this sort of just clouding of memory, difficulty retrieval of words, difficulty speaking. And that really is hard to exactly know what that is mapping to in terms of specific neuropsychological batteries. But in testing, sustained attention and working memory has been shown to be a problem. Mood disorders, as I mentioned, including depression, anxiety, and even obsessive compulsive disorder, collectively have been reported in up to 25%. And there has been reporting of even like schizophrenia and psychosis present, although the numbers vary. As I mentioned, Lily's actually collected some interesting data from our center looking at the prevalence of hypertension in children. So this is children between 7 and 18 years of age, and she looked through medical records to basically see what blood pressure was at the time of onset of the first presentation, so before treatment, and then subsequently with treatment over an 18-month period. And what she found is that hypertension is something that certainly is elevated in patients, and we were seeing values. Actually, I have these, I think, backwards, but 18% had hypertension at even their baseline visit, and then that number certainly went up with treatment of stimulant medications. And so the bottom line is that, you know, close monitoring of blood pressure really is going to be necessary, I think, for pediatric narcolepsy patients. And we should just be aware that, like in the adult populations, that blood pressure can go up with stimulant use, and it remains to be determined with other medications. And so this is something that we really advocate for in terms of anticipatory guidance. And it might require people to come in for clinical visits rather than relying on telehealth. Notably, we did find that in the end, after 18 months, patients' blood pressure was largely related to obesity, but also just note that elevations in blood pressure were noted even before stimulants were started, and that finding was not related to obesity. All right. So next, I'm going to kind of delve into the various medications that we currently do have for treatment. And highlighted in blue will be medications that are FDA approved for the treatment of pediatric narcolepsy. So probably the most commonly used medications are traditional stimulant medications. And if you think back at our original image of what constitutes wake-promoting neurotransmitters, dopamine is a big one. So these are medications that act to stimulate dopamine receptors or prevent the breakdown of dopamine in the synaptic cleft or release more dopamine. So methylphenidate, for instance, acts to inhibit that dopamine reuptake, and it acts on dopamine receptors. Whereas amphetamine is a little bit more potent because it also releases dopamine from the presynaptic cleft. So just another mechanism for increasing dopamine. Functionally, the medication amphetamines are probably a little bit more strong than methylphenidate, but sometimes that comes with increased side effects. And at higher doses, which I'll say greater than 60 milligrams, there has been reporting of psychosis with use of high-dose amphetamines that was 2 times more common than methylphenidate when they looked at ADHD populations. Other medications like lisdexamfetamine are medications that are sort of a prodrug of amphetamines. They last longer, but might have a slower onset to get going for patients. Side effects are very similar across all stimulants, affecting things like headaches, insomnia rates, upset stomachs, appetite suppression, feelings of anxiety or nervousness. Uniquely, the lisdexamfetamine, which is Vyvanse, also can cause increased sweating and sometimes dry mouth and rash. Then there's medications that are more commonly used in the adult population because these are not FDA approved for people under 17 years of age. Modafinil and armodafinil are medications that probably work through the dopamine system, but are sort of weaker in their mechanisms than, say, traditional stimulants. However, they don't also increase norepinephrine, which sometimes stimulants can do. So these are useful medications for increasing wakefulness, but if someone has side effects, for instance, on stimulant medications, it might be actually a lesser frequency of those type of side effects with the modafinil or armodafinil. Uniquely, modafinil and armodafinil have been reported in a very few cases to cause a very dangerous rash called Stevens-Johnson syndrome and psychosis in children. Hence, it's not approved for people under 17 years of age. But again, those were very rare side effects. More common ones, similar to stimulants, as I mentioned, would be headache, nausea. Sometimes back pain can occur, and close monitoring of elevation of blood pressure needs to be done. This is a medication that can interact with oral contraceptives, and so sometimes patients are on those to prevent birth control, but sometimes they're on it for various gynecologic reasons or problems with their menstrual cycle, so that needs to be closely monitored for any potential loss of efficacy for that. Other medications, solriamfetol is Sunosi. This works through the dopamine and norepinephrine system by preventing their breakdown. It's a pretty long-acting medication, usually lasting up to 7 hours, and side effects are very similar to the modafinil with headaches reported. It can have some effect on heart rate and blood pressure, although in my experience, not as much as stimulants. Nausea, diarrhea, and anxiety have been reported. And then there's medications that are marketed as sort of non-stimulants. These work by inhibiting the breakdown of norepinephrine, and that's atomoxetine or Strattera. This is also used for the treatment of ADHD, if you've ever heard of it, and basically can be helpful for wake promotion, but because it doesn't really affect the dopamine system, it's a milder wake promoting medication. Some people have reported, because of that norepinephrine activity, that it can help with cataplexy as well, but that's not been really well studied. I mentioned modafinil, and while it is not approved for children based on FDA guidance, it is commonly used in practice for the treatment of daytime sleepiness. And it was reviewed as part of the American Academy of Sleep Medicine practice parameters, really based on this single observational study, which was very small, only 10 patients. But in that study, with doses up to 200 milligrams a day, there was a 6-point improvement on the Epworth Sleepiness Scale, which is a commonly used scale we use for assessment of daytime sleepiness. And there were no severe side effects, importantly. So I mentioned psychosis and Stevens-Johnson as the reasons why these medications were not approved, but none of the patients in one particular meta-analysis of 205 pediatric narcolepsy patients had that particular side effect. So essentially, I put the rates of other side effects here, but it's not uncommon for children to be using those medications, modafinil or armodafinil, off-label as a result. And then there's medications that treat both sleepiness and cataplexy. So that would be the oxybate class. So we used to only have sodium oxybate. Now we have other options. So there's sodium oxybate, which is Xyrem. There's low salt oxybate, which is Xywav. And then there's once nightly oxybate, which is Lumryz. All of these medications we believe to work through the GABA system. So I showed you in the beginning that that was important for sleep promotion, but we really don't know why this medication is also effective for treatment of daytime sleepiness and cataplexy. It's an oral medication that's taken at bedtime. It's a very potent sedative as a result, and it is a controlled substance. Common side effects of the medication, I'll go through based on the clinical trial, are things like nausea, upset stomach, feeling dizzy upon taking it, weight loss and appetite suppression, but there are some severe potential side effects that have rarely happened, including the development of sleep disordered breathing, mood changes, suicidality, psychosis that require a lot of counseling when you're prescribing these medications, and they require enrollment in something called the REMS program, a risk mitigation program for safety management. Importantly, these medications cannot be mixed with any type of sedating substance, including alcohol or marijuana, because that could cause respiratory depression and death. And there's a host of other sort of specific guidance that needs to be reviewed with any prescribing provider as part of that REMS program. But these are medications that are approved for the treatment of pediatric narcolepsy. Pitolisant is our newest drug, and I'll show you the clinical trial data on that. Basically, it's a medication that is an oral medication that works through the histamine system. And histamine kind of travels along with some of the pathways of orexin. And so it's been approved for adults for the treatment of daytime sleepiness and cataplexy, but thus far in the US, only FDA approved for daytime sleepiness. So I'll show you the clinical data and the side effects in later slides. So this is the randomized trial that I was just referring to. I highlight these two because there's only two. There's not a lot of studies for pediatric narcolepsy. Unfortunately, hopefully that'll change. But this is what's called a double-blind randomized placebo-controlled study where they included patients ages 6 to 17 years of age with either narcolepsy with cataplexy or narcolepsy without cataplexy, and the breakdown is here. Patients were randomized either to pitolisant or a placebo drug, and their main outcomes were a host of surveys that assess narcolepsy symptoms, as well as an objective test called the multiple wakefulness test. And based on those results, there was a significant improvement in narcolepsy symptoms based on a survey scale. But importantly, there was also significant improvement in the daytime severity scale. I mentioned it was not approved for the treatment of cataplexy, and that's because there was only a weak effect on cataplexy improvement based on the cataplexy diary, and there was no improvement based on the objective test. But subjectively, patients did report significant improvement in daytime sleepiness, and side effects, while common, were considered mild. So 83% of patients reported side effects, but even in the placebo group, 76% reported side effects. The most common side effects of pitolisant are headache and insomnia. So those are things that need to be monitored. There was one severe event that was pyrexia, and pyrexia is fever and headache and insomnia. But there were no deaths or events that led to discontinuation of the study. And then before I hand it to Lily, sodium oxybate, this is an older study, but this was also a randomized controlled study. I think it's worth just noting the differences that I just presented. So in the last study, people were either randomized to placebo or randomized to a study drug. In this study, it was sort of interesting because everybody was basically put on a stable dose of sodium oxybate at the time. So they were titrated to a dose, or if they came into a trial and were on oxybate, they were kept on that dosing, and they were kept on what's called stable dose for a period of 2 to 3 weeks. And then they were randomized to either stop the medication or continue the medication. So essentially they were randomized to continue on sodium oxybate or randomized to a placebo drug. So it's a little different because they were either staying on the drug or withdrawing on the drug. And then there was an open label phase. We do know that there's specific age and weight-based guidelines, just weight-based guidelines for this medication. It was not approved for children under 7 years of age, but this gives you good guidance on that. And in terms of the efficacy, there was significant improvement of daytime sleepiness in those that were randomized to drug, sodium oxybate versus placebo. And then there was an improvement in cataplexy such that people with cataplexy, with placebo had an increase of cataplexy on their diary. They had 12.7 more events than the people who were able to stay on sodium oxybate. So I think obviously that was significant. So that was why really this medication was approved for the treatment of both daytime sleepiness and cataplexy in pediatric narcolepsy, but it also is, can be used by patients without cataplexy. In terms of those side effects I mentioned, again, fairly high adverse side effect profile, but most of the side effects are relatively minor, but maybe not so minor to patients. Sometimes bedwetting is probably one of the biggest complaints I get. Nausea, upset stomach, decreased weight or appetite, and dizziness are common things that I hear about. Generally speaking, if we go really slow on the titration or don't over titrate at the beginning and allow the body to kind of adjust, I can avoid a lot of these side effects. Decreased weight and appetite suppression aren't always bad things because obesity is often a really bothersome symptom for patients. And so this is actually sometimes helpful. The serious side effects in this trial, there was one patient with severe psychosis, one patient with suicidal ideation, and there were several cases of central sleep apnea. So those are definitely things that need to be monitored for. And again, why this is part of that risk mitigation program. And then other treatments of cataplexy, as I mentioned, that paralysis circuit that we have can be suppressed by things like serotonin and norepinephrine. So medications like venlafaxine or Effexor is a brand name, and medications like fluoxetine, which is a long-acting SSRI medication, are oftentimes used for the treatment. These are medications that are usually considered antidepressants, but we're using them here off-label for the treatment of cataplexy. And there's other medications like that that are in what's called the monoamine class of medications, tricyclic agents. Those are protriptyline and clomipramine. There have been American Academy of Sleep Medicine practice parameter recommendations specific to pediatric narcolepsy, but because there's really not a lot of clinical trials with children with narcolepsy, we didn't have actually a lot to go on. But based on what was available, recommendations for both modafinil and sodium oxybate were issued. The conditional statement is that it might not be right for every group, every patient. And this was just, I think I just put this here as maybe a conceptual way of thinking of how to use these medications. This was developed by a European expert panel where essentially they were advocating if people have relatively mild symptoms or daytime sleepiness is the only symptom, medications like modafinil, pitolisant, or solriamfetol for adults could be considered. If the patient has daytime sleepiness and cataplexy, they advocated for monotherapy, meaning just one medication that treats multiple symptoms, and that would be oxybate or pitolisant. They qualified that if it was more severe symptoms, oxybate might be better. And then if a patient had daytime sleepiness, cataplexy, and disrupted nighttime sleep symptoms, again, monotherapy might be best. So one medication that treats multiple medications, which at this time are just oxybates. Certainly, there's various combinations of medications that can be effective, but that concept of monotherapy was thought to be important in this group. So before I hand it over to Lily, I think management of the comorbidities I mentioned are really important. I think as parents or patients yourselves, making sure that you have access to growth curves and vital signs. So those things are really important to be tracking because as I mentioned, obesity can really creep up. Issues of hypertension or elevations in blood pressure, if it's continuous over long periods of time, can potentially put people at risk for cardiovascular comorbidities in adulthood. So we are trying to be more vigilant about that in our pediatric practices. If you're concerned about things like attention deficit or hyperactivity, asking your providers for validated scales that can help diagnose those conditions. Things like Vanderbilt or Connor forms, for instance, can oftentimes be easily used, assessing symptoms in both home and at school. And then there's other surveys, such as the Patient Health Questionnaire, which are good screening surveys for depression. So these are things that you should be aware of as potential comorbidities and asked to be assessed. If necessary, subspecialty referrals can be requested for psychiatry, cardiology, and whatnot. And then I think that, just knowing that some of these medications might potentially exacerbate some conditions can kind of guide personalized treatment. So for instance, traditional stimulants are known to increase mood disorders and hypertension, so might want to be avoided if those are specific comorbidities in patients. But if a patient does have ADHD, perhaps it's worth using a traditional stimulant because there's the potential to help with both. So I'll leave it at that and turn it over to Lily.
Awesome. Thank you, Dr. Maski. I'm going to share my screen and hopefully have success. But just need to put it into presentation mode. All right. Did that look okay for people? Great. So as was mentioned at the top, my name is Lily. I am a person with narcolepsy. I was diagnosed with type 1 narcolepsy my first year of medical school. You can see my lovely sleep study photo here, and then also my medical school photo here. So I'm really excited to talk today because I've been able to kind of hold both of these identities and I think learn a little bit about what it's like to live with narcolepsy and then also how to manage it best non-pharmacologically. So I think for all of us, both as patients, but also for providers, the ultimate goal isn't just living, but really thriving with hypersomnias like narcolepsy. And the first component is something we talked about, often the first thing that comes to mind, and Dr. Maski covered really thoroughly, which is medication. But it's really just one of sort of the many things that has to go into the picture to really create a picture where someone's thriving. So the other things include things like sleep strategies, which again, something that people often think about, nutrition and exercise, school accommodations, social supports, mental health support, and even education and self-advocacy. And I think once you're able to kind of weave all these things together, that's when someone can really thrive and live kind of the best life that they can with narcolepsy. So I'm going to go through each of these in turn. The first and probably most common sort of non-pharmacological intervention that you hear people talk about is sleep strategies. So anytime you go to a doctor's appointment with narcolepsy, one of the things they check on is your sleep schedule. And that's because even for people with narcolepsy, you really want to be promoting, and maybe especially for people with narcolepsy, normal sleep durations for age. So this depends on age, obviously, but about 10 hours for school age kids, 8 to 10 hours for adolescents. Beyond just this normal duration, it's really helpful to have a consistent bedtime and wake time. And I found this in my personal experience as well. It can help just create a consistent schedule. And also, depending on your medications, I think your body sort of gets used to the cadence of the medications that you're on. And it becomes much easier to predict when are my wake times, like when's my optimal functioning times, and to schedule your life around that if your bedtime and wake time are consistent. One of the other big recommendations for narcolepsy specifically is to take scheduled naps. These typically are recommended to last from about 10 to 30 minutes. And though they're less helpful in IH, they can be really helpful in narcolepsy in improving sort of the brain fog or preventing sleep attacks before they happen. So what this looks like usually when we say scheduled is that you actually pick a time in the day, that's your nap time. And even if you're not, at the point of truly falling asleep yet, you close your eyes, and having that nap can actually make you feel more alert in the future. I've also found that sleeping with my phone in a different room is really helpful. Dr. Maski talked a little bit about that disrupted nighttime sleep that can come with narcolepsy. And it can be really tempting when you're waking up and falling asleep, or even if you're on an oxybate, you're waking up for different doses to look at your phone, things like that. And that only disrupts your sleep more. So I think this is good for everyone, but especially for people with sleep disorders like narcolepsy. This does bring up an interesting issue, which a lot of people say, well, then how am I going to wake up? And I think something helpful to consider is alternative alarm clocks. So either good old-fashioned alarm clocks or wearables. You can actually, I found several people have found it helpful to wear like a Fitbit or something that vibrates, because actually that vibration can be really helpful to wake up. There's smart clocks, like I'm not going to say the name because mine's in my room, but you can actually verbally tell it to set an alarm at a certain time, and that can be helpful. Or clocks that have sort of a daylight, they almost like simulate sunrise, which can be helpful to sort of start to get your body waking up for certain people. On that vein, exposure to daylight during the daytime is also really helpful. If you can open your curtains and shades when you wake up, this is also particularly helpful in IH, where you might have some more of that difficulty waking up. But it can help to just kind of get your body into daylight mode, and this all goes to kind of getting that schedule down. So the next component is nutrition and exercise, which of course is important for everyone, but is especially important in sleep disorders like narcolepsy. So regular movement can improve alertness and nighttime sleep, so it kind of helps both. I think group classes or activities can be helpful for accountability. So for me, I know if I get home and I'm just going for a run by myself, I'm probably going to fall asleep or take a nap on the couch first. But if I'm going to a fun class, a dance class, a spin class, or just meeting up with friends, that can really help to motivate, because it can be really difficult to actually incorporate this into routine. In school, it may be helpful to optimize the gym or PE schedule so that it's later in the day for some students, especially if they may tend to miss classes earlier in the day, if they have IH or something like that. And then for nutrition, I think the number one thing for everyone, but especially with narcolepsy, is to eat a balanced diet and to be aware of how different foods make you feel. Some people describe different foods being triggering, or heavy foods or like big meals can make you sleepy or sleepier. Similarly to sleep, I think maintaining a schedule is really helpful. So you're eating your 3 meals a day and your snacks. This is helpful for weight management. It's helpful for maintaining consistent energy. And it's also helpful to like that you're actually remembering to do it. And you may need to set reminders to eat. There's, as Dr. Maski mentioned, these medications can have appetite suppressant effects. And you want to make sure that you're eating these consistent meals so you don't get to the end of the day and realize you've barely eaten. And then weight management, which Dr. Maski also touched on, is really important. It's important to start early, before sort of as soon as you may notice changes in weight, before significant weight gain happens. And working with nutritionists or online programs can be a good first step. This can involve things like food diaries or step counters like a Fitbit with specified goals. and limited access to salty or sweet or high carb foods. So sort of like high reward, but like high instant reward, but low like nutritional density foods that can feel really good, especially when we're sleepy. I have found, you're sleepy, you don't want fruits and veggies, but it's what's better for you. And then also referrals to endocrinology or weight loss programs if those sort of initial steps aren't sufficient. The next thing that's super important is school accommodations, particularly in the pediatric narcolepsy population. But I would say as a official adult, now that I'm still in med school, it's important for me every day as well. So it doesn't really stop with, high school, for example. So I think the first thing here that comes up is to work with your school to have a time and a space for these scheduled naps. So that may look like carving out a time in the day, getting in touch with the teachers, the administrators who need to know, this is where I'm going. Oftentimes a school nurse can be helpful with this as well and may have a dedicated spot. But this can be really helpful and can restore your energy so you're actually awake for classes. Another thing that can be helpful is extra time for presentations, projects, and homework to accommodate the need to sleep, the increased need to sleep, and then the sleep schedule as well. While some kids, it might be totally okay to, pull a all-nighter or a long study night before a presentation is due. For someone with narcolepsy, that may completely disrupt their week and their sleep schedule. So planning ahead of time to have more flexible timing or strategies in place when this kind of thing might happen can really benefit the student. Another thing that can be helpful more in IH than narcolepsy is a modified school day with a late start. So for people who have difficulty waking up in the morning, that can be really helpful to allow them to attend all of their classes without, consistently missing, for example, the first period or something like that. And then I know this is something I've actually used in med schools, the ability to record classes and access notes and presentation materials, because we may use all of these strategies and then still find ourselves either having brain fog or falling asleep during class and missing something. And so it's really helpful to have the system in place so that when this happens, you can go back and kind of fill in the pieces that you missed. And that way it's much less stressful if you find yourself becoming sleepy in class because you actually have this backup plan. Another really important component of all this is test-taking accommodations. I think this is often the first thing people think of, but it's, again, just one piece of the bigger puzzle. Some ideas for test-taking accommodations that are helpful are stop-the-clock breaks or more frequent breaks. It kind of depends on what the testing is like, and you may have to work specifically with a school, school district, or with your school or teachers to kind of figure out the best strategy. But something like a stop the clock break allows you to take a nap, whereas more frequent breaks may allow someone to kind of step away, rest briefly, reset their kind of brain, go through the brain fog, even just like walk around. That can be really helpful. Extended time can be helpful for the same reasons. It reduces the stress if you find yourself kind of shutting down or just feeling like you're having difficulty concentrating. And in some situations, it may be possible if there's different options for test taking. It can be really hard to stay alert for an essay for a long amount of time. So if you have to sit down and, write a 3-hour paper, that can be really difficult. So something like multiple choice may be easier. And then I think it's really important to mention, I always talk about this when I'm talking to people as I talk about accommodations, to mention standardized testing, because standardized testing tends to be much more strict about how you are able to apply for and receive accommodations. I think it's really important to apply early and to have that record of the accommodations you have at school to back up your application and say, this is why I need this. So by apply early, I mean both chronologically before the test, but also the first standardized test you take after your narcolepsy diagnosis, you should try and get those accommodations, because every subsequent test, they're going to ask, did you have that accommodation at the previous test? And if not, why do we need to give it to you now? Obviously, this sounds super cruel, but it's the way that it's done. And I think knowing ahead of time that, okay, even if you think you're going to be okay, having those accommodations in place will benefit your future self. For college, there's a couple additional accommodations to think about. For college, you're not, having the same school day as you would in high school or before that. So preferential class registration can really help. Oftentimes in colleges and universities, there's sort of a seniority system or a lottery system. And this can mean that you might end up with a class that's, if let's say you have trouble waking up, that's like right in the morning because you're a first year, right? But that might really not work for you. So speaking with your college disability services office ahead of time and arranging for this preferential registration will allow you to plan your classes around your most kind of awake and alert windows. And then you'll be set up to succeed. Another thing that's different about college is that exams often aren't during class time. And not only are they not during class time, but they can be at some pretty crazy times. So I remember an exam I had from 7 to 10 p.m. In college. And they don't tell you this necessarily ahead of time. So it's helpful if you think ahead of time yourself and kind of set yourself up for success by talking to your professors, talking to your disability services office, and making sure that if an exam is planned for some time that doesn't work for you, you have an alternate strategy. So that might include having a different proctor, a different place to take the exam. All of this requires planning. So if you do it ahead of time, it's going to be much easier than all of a sudden you see on your syllabus, oh no, this exam is from, 8 to 10 p.m. What am I going to do? Another thing that's very applicable for the pre-medical and other sort of lab sciences, but many people who have long classes, is abbreviated course sessions or breaks during courses. For example, sometimes you have lectures that go right into lab, and this can be really difficult because it's a really long time to not have a break to sleep or even just to, take your medications and reset. So abbreviated course sessions can help. And then there's some living requests if you're going to be living at your college or university that may help. For people who are on medications that are controlled substances that are, you need to only have them for yourself. It can be helpful to have a lockbox for your medications, or even depending on kind of your comfort level, a single room. Other things that can be helpful is living on the first floor, living near a bathroom, again, especially if you take oxybates. And, at nighttime, you may be needing to get up to go to the bathroom to come back, but only between, obviously, when you're taking them. That can be helpful. Near an RA if you ever need support, a room in a quieter location. And for some people, a roommate may be helpful. A roommate may be helpful to kind of motivate you to get out of bed, right? Or if you have a roommate who's your friend, is very trusted, they can help you stay on schedule. For some people, like the example above with the medications, it might be more comfortable to not have a roommate to ensure that you have a quiet place to nap, to ensure that you have a place where your medications are safely stored. So this is really an individual conversation, but something that should be thought about as well. And then being close to classes so that you can take a nap. So sometimes the dorm will be way far out, and by the time you get back, it's time to turn around again. So this is something to think of as well. The next thing I wanted to talk about was social supports. So given that this is Wake Up Narcolepsy, I know that this is not a new topic for any of you, but just wanted to emphasize the importance of this based on my experience and the experience of other people who I've talked to with narcolepsy. I think it's often said, but even, as a medical student who's relatively well treated, et cetera, symptoms can make it difficult to engage in social activities. And if it's hard for me, I can only imagine how hard it is for very young children or children who are, just figuring out their diagnosis, et cetera. And the demands of school and social activities can just be a lot. I think the most important thing here is to talk to your doctor about your priorities and concerns. It's not something that often comes up, I've noticed, in doctor's appointments because there's so much to go through and medication portion of it and symptoms, but this is something that your doctors really want to know about so that they can help you. And this may look like thinking about changing your medications or strategies to make sure that you're able to engage socially. For example, some people with cataplexy really struggle with certain emotions because it doesn't actually feel safe if you're laughing really hard or something like that. So if this is something you're experiencing, talking to your doctor about, hey, my cataplexy is not well controlled, it's actually affecting my social life or my romantic life, things like that. I think it's also really important to identify who your support network is. This can be family, friends, significant others, et cetera, and kind of identify who those trusted people are who you can rely on. think this is important because those closest to you should ideally know how to support you. And this isn't, they can't read your mind. Sometimes you don't even know how to support yourself. And so I think sources like Wake Up Narcolepsy and other resources are really important to be able to educate your support system about your condition, especially how they can support you. And this is work that they can do. So you don't need to, educate them yourself because they're resources for allies and supporters, and then they'll be a better supporter for you. And of course, this is just based on your comfort level and who you trust. I would say, again, another important component of kind of knowing who that support system is and having them be aware of what's going on with you is that it can be helpful to plan activities for the times you're most awake or sort of optimize your activities. I had a birthday party this year, which is very exciting. I haven't had a birthday party in a while, and it started earlier than it would have if I wasn't someone with narcolepsy. And it was really wonderful because I felt really supported by my friends, by my network, that they took the time and they cared to say, what works best for you. And we had a great time, and I got to bed on time, and that's kind of the dream, right? And kind of along this vein, collaborating with your supporters to make contingency plans. For example, a lot of times it can be stressful if you're leaving the house and going somewhere and you don't have a safe napping location. And talking to people and saying, yes, I'd love to come do this, but I'm going to need a nap in the afternoon. Oftentimes it's actually pretty easy to find kind of a space or a strategy once people know what you're looking for. The other thing while traveling, I would say it can be hard to travel with narcolepsy, but if you look for disability and accommodation resources, there's often resources you don't know about. This can happen in airports, theme parks, hotels, wherever. And it can be really helpful just to know the resources and then know that you have access to them, get in touch with those resources. For example, this is really silly, but I went to a Taylor Swift concert, and you guys know the whole situation around that. And I was really worried that we were going to be stuck in the parking lot for hours before we got out, and I was going to be late on my medication dose, and it was just going to be a disaster. And we talked to the people we called Gillette, and they actually arranged for us to have ADA parking, and we were able to get out early. Which was really wonderful. And I wouldn't have known that that was something that was available, but it was. And then finally, I'll talk a little bit more about this later, but joining support groups, because I think there's really no substitute for talking to people who understand the lived experience. This is something that I have found completely invaluable in learning how to live and thrive with narcolepsy, is my support network of people who have come before me, people who are coming after me. It's really become like a wonderful family of people who share strategies, share difficulties, share, the wins. So I highly encourage this. Another important sort of supportive aspect that Dr. Maski touched on is mental health support. I know, this is cute. I found it, I was like, oh, I love it. As Dr. Maski mentioned, not only are there comorbidities, but hypersomnia can impact mood and mental health itself. So even if you didn't have a pre-existing mental health condition, it's really difficult to navigate the world with hypersomnia like narcolepsy. And so I think along this vein, therapy may be helpful. It may be helpful just to process a new diagnosis. It may be helpful even if you've been diagnosed for 10 years and you want support. And some therapists actually specialize in chronic illness or even in sleep. And it can be helpful to identify these people because they have strategies and they know how to work through these problems and likely aren't going to dismiss what's going on with you. Specifically, CBTH, which is CBT hypersomnia, has been shown to be helpful for psychosocial support, coping, and decreasing stigma in adults, and may be useful in the pediatric population as well. And then I think, again, a common theme is to discuss your concerns with your sleep doctor as they come up for a couple reasons. They may be related to your medication, as we've discussed, or your medication might actually play a role in kind of these symptoms, and you could potentially change around your medications to better address these symptoms. Also, they may be able to connect you with other resources, and they want to know what's going on with you so that they can help you best. This can include multidisciplinary care with psychiatry, which may be helpful for some to manage those medications and more complicated mental health conditions. But it's really important to have these conversations and get the support that you need. And then finally, I think the last piece, which is, we're here today, is actually education and self-advocacy. So it sounds sort of obvious, but educating yourself on hypersomnias like narcolepsy is one of the most powerful tools that you have to set yourself up for success. There's lots of wonderful foundations, including Wake Up Narcolepsy, that provide resources. And this allows you to become, you're already an expert on your own experience, right? Because you're the one living it. But it allows you to gain the vocabulary and the knowledge to describe it in a way that's going to get you the best care possible and to connect with people to get the best resources possible. Because often if you're experiencing something, but you don't have those kind of special, almost medical words, it can be hard to connect with a doctor about what's going on and get the appropriate help. That being said, advocating for your needs and your priorities with your providers is so important. Oftentimes in a doctor's appointment, doctors have sort of their own priorities that are there for a good reason. There's the common things they want to cover and talk about, but you have your priorities as well. And it's important to make sure you're bringing those to the forefront so that your provider can help you, because they won't know unless you bring them up. Here's some like tips I have for doctor's appointments. I found it's really helpful to agenda set. So I pick 1 or 2 priorities per appointment and then tell my doctor about them at the start of the visits. This often for me involves thinking about it the week before, like what's been going on, what's most important to me, and then writing it down and literally saying, hi, so nice to see you. Here are my 1 to 2 priorities. I'd love to cover them before the end of the appointment. Another thing that's really helpful is knowing your options. You can look at these resources above, and there's also the resources that Dr. Maski just shared to find the latest information about medications and clinical trials. So you can actually educate yourself about what the different options are and ask. It doesn't hurt to ask your doctor about different options, and then they can use their kind of medical knowledge to see if that might actually be a good match for you or not. I found it really helpful to bring a buddy to difficult appointments, a parent, a significant other, a trusted friend, whether they're there just to provide moral support, or sometimes they can actually corroborate symptoms or other experiences you're having, or may have noticed things that you didn't even know they noticed, that like sleep behaviors, things like that. And they can actually help round out your care. And then for sensitive concerns, I think this again sounds silly, but practicing in a mirror or writing out your questions ahead of time can really help you bring those to a doctor because it's important. And I think I want to emphasize that, there's nothing that's off limits in a doctor's appointment, even if it feels uncomfortable. But it's, of course, normal that it can feel uncomfortable to bring up something. So practicing that can really prepare you to have those difficult conversations. All right. Oh, I had an empty slide. That's all I have. I would love any questions. Happy to, I can't see the Q&A because I'm sharing, but I'm happy to stop sharing and address any questions. But also please address questions to Dr. Maski as well. And thank you.
I think there's one question about management with children under 5 years of age and whether scheduled naps are enough. I think so in terms of what medications are approved for children under 5, it's really just stimulant medications that can be used for children under 5. Pitolisant is 6 and above, oxybates are 7 and above, but that's not to say medications potentially could be considered off-label and used. And then the person also asks about a scale to follow narcolepsy medications. Unfortunately, the scales that we use, like the Epworth and the Pediatric Daytime Sleepiness Scale, are for, I believe the youngest one is 10, and I think Epworth is 12. So it's a lot of the questions are asking about the sleepiness in context of school settings. So I would say they at least need to be in a school kind of classroom environment to be taking those scales. But a lot of times it's based on observations from the teachers. Are they falling asleep during circle time, during recess, and during the classroom periods? But yeah, I think there are ways of going about sort of that assessment that just might be just global impression scales or things like that that could be considered. There's another question about Canadian doctors or programs for pediatric narcolepsy. I think if possible, we'll give some recommendations to Tammy. I don't know, I think Toronto Sick Kids is the group that I know best. But I believe there's a resource network available through Wake Up Narcolepsy that might have more specific providers. And then there's one on recognition of social anxiety. Do you find that doctors don't recognize social anxiety or social isolation in pediatric narcolepsy? Oftentimes children are passed on to other groups like psychiatry or whatnot, and they just really need peers and social programs. I think that's, Lily, what you were sort of describing. I don't know if you have any experience with, doctors not really recognizing some of the consequences of narcolepsy and how it affects people in terms of social isolation, social anxiety.
Yeah, I think what I think I've heard from people and experienced myself is sometimes you don't even realize that that's what's going on. Um, I think for so many reasons, we've kind of culturally started to learn the consequences of social isolation, particularly COVID. But that life with narcolepsy can be a lot like life in sort of a COVID isolation world. And if you kind of think back to that time, I know for me, I didn't know why I felt sort of down and unlike myself in the COVID time. And it really is like that human interaction so important, but you don't necessarily think about it. So I think if you're, a parent, a caregiver, a supporter, um, it's really important to think about, if this person in my life who I love and care about who has narcolepsy is seeming down, like, could this be a component? And how can I facilitate spaces that are sort of accessible to my child and meet their needs? And yeah, that might mean doing something at a certain time of day, right? Or hosting at your house so that the kid so that your kid can comfortably nap in their own bed. And that it's okay for their friends to, be watching 20 minutes of TV while they're gone or something like that. But I do think proactively sort of thinking about this possibility is really important.